Again, I'm Dr. MacKenzie Purdy. I'm one of the reproductive endocrinologists in our St. Louis, Southern Illinois, and now our Arkansas location. And I'm with Kindbody, and certainly there are many centers all throughout the United States with our focus on fertility management, hoping and helping patients to go through their fertility journey, whether that's egg freezing, embryo creation, pregnancy, the whole gamut. So that's what our goal is to talk tonight, is specifically about IVF. And yes, feel free to send any questions in here, but we'll try to move through. We've got a lot to talk about, and we'll try to get through it in a fast pace here. So I'm going to work on sharing my screen. I'm definitely a visual person, and it's helpful to be able to talk through this, have pictures, and put a little bit of context to the things that we're talking about. All right, so hopefully this is going to load and we'll be able to see. There we go. So again, this is all about IVF, and our goal is to have everybody be more knowledgeable and be an advocate for their care and feel like they are taking their journey into their own hands in a way to have just the most information possible in regards to the future and what is planned from an IVF cycle standpoint. So as I said, Dr. MacKenzie Purdy, you can find me on Instagram. You can find Kindbody on our Instagram handle. I'm always welcome to questions or anything that may come up, and happy to see patients at any time at our locations. And we do telemedicine, which is nice. So we have the opportunity to see people all throughout the United States. So our mission at Kindbody is to allow individualized care, be innovative, and allow for better access, because we want everyone to be able to have fertility treatment when they need it. We want it to be compassionate, and we want it to be individualized. So hopefully our patients would say the same, that they feel like that, and that we have the options to provide a lot of care in one center, you know, starting from a workup to the actual treatment. And those things include, you know, donor egg, donor sperm, gestational carrier, all the things that may need to be performed and a lot of times have to be outsourced to other places. And, you know, with our goal of doing it in-house, and I think we keep a lot of that consistency, and the care is, I think, a little bit, you know, more individualized in that respect. So certainly this is our mission. And what we do, I said, like the full gamut of things, all the fertility treatments with, you know, IUI, IVF, genetic screening, donor sperm, donor eggs, LGBTQ information and treatment. So all the things that are very important, and also the support that's needed behind it. So we have specific counselors that are fertility counselors. We have support that's provided from a nutritional standpoint and a wellness standpoint. And our goal is to be on this journey with you. And communication is key when it comes to fertility care, when it comes to the emotional roller coaster that is an IVF journey. And certainly that's what we're here for, to help you and try to make this the best experience, because it's emotional and it's tough, and you need somebody there to help you, and not just from a medical standpoint, but also from an emotional perspective. So when I start talking to a patient, anybody, I talk about the three big components that it takes to have a baby. No matter how you put your family together, you know, whether you're in a heterosexual relationship, you're a single parent by choice, you're planning to use donor, you're in a same-sex relationship, we know there's three components that we need to have a baby. We need to have eggs, we need to have a uterus, and we need to have a sperm source. So to analyze all of these pieces, well, it depends on how you put your family together, whether we're going to analyze an egg source, who's going to carry the pregnancy, and then a sperm source. So we break it down, we talk about the eggs, and we tend to focus on the eggs a lot, because we know that, well, women are born with all the eggs they're ever going to have, and we lose them as time goes on. So we spend a lot of time focusing on that aspect. So if we start with the egg, and let's say we're born with about 2 to 3 million eggs. Well, as time goes on, we lose them no matter what. If you're on birth control, you're pregnant, doesn't matter. And so by the time we get to be in our late 30s, early 40s, we don't have a lot of eggs left. And it's definitely not fair. And it's not the same case for men who continually make new sperm. But that's why we focus on this and recognize that age has a big impact on success. But there's a way that we can quantify our egg supply. And that's done with a ovarian reserve test. So specifically an AMH, anti-Mullerian hormone, that helps tell us what your egg numbers are specifically compared to your age group. Same thing with an antral follicle count. We can look and say, okay, well, how many eggs are you growing this month? And is that considered normal for your age? It's a predictor of success when doing IVF, how many eggs are going to be retrieved. And it gives us insight to say, okay, down the road, is there a possibility there may be lower egg numbers, which can make it harder to get pregnant in the future? So an antral follicle count is typically done with an ultrasound, a transvaginal ultrasound, counting these little follicles with an average number of about 6 to 10 each ovary in a month. And if it gets much lower than that, then we put you into the category potentially of diminished ovarian reserve. And again, that makes it potentially harder to get pregnant down the road. And it does predict that there may be less eggs that are being able to be retrieved. So what it does is put a little more sense of urgency. And it also tells us potentially what medication dosing someone may need, depending on how high their ovarian reserve is to start with. So what the egg typically has to do is to travel through the tube. The sperm has to go in through the uterus, be able to make it to the tube, fertilize the egg, and then that embryo has to make its way all the way back to the uterus. So this is a complex part. And so for anyone that has tubal factor, male factor, endometriosis, unexplained, IVF has a big role here because it bypasses a lot of these pieces that potentially are not working. So when we go back and we focus on the egg, we think a lot about age, and we said age is a big reflection of the number of eggs and then the quality of the eggs. And 35 is not a magic number, but we start to see larger declines in numbers around those mid-30s. And there are some people even that have a lower egg supply before that, and that's something called primary ovarian insufficiency. And so just having an evaluation gives you more information. And we know knowledge is power in the standpoint that if you know more about your health, you can help decide what you want to do going forward. And as we get older, if the numbers are lower to start with, we know that it makes it a higher risk that we're going to have lower numbers going forward. And that may then increase the risk of having miscarriages, given the fact that quality means that there are potentially abnormal chromosomes in the eggs. And that can lead to a higher risk of having an embryo that's implanted that has a chromosomal abnormality. So that comes into age and then having an abnormal chromosome in an egg that then can potentially become an embryo. An abnormal embryo is called aneuploidy. And this is a graph demonstrating that as we get older in the gray bar, the chance of having an abnormal embryo. And there's a pretty big jump that happens in our late 30s into our early 40s. And so that's why we want to be proactive. We want to do everything we can at a younger age, just recognizing that that's what's going to give us the best success. Not to say that as we get older that there's not an opportunity, and I never say that there's a cutoff pretty much for an age to go through IVF, to give yourself a chance to say, is there a possibility that I could have a pregnancy using my own eggs? Other features of the egg is related to underlying diagnoses. So we think about PCOS, we think about thyroid dysfunction, we think about the signaling that happens from the pituitary to tell the ovary to work. Those are all things that should be evaluated from the very beginning before you start IVF to get a better sense for what your dosing needs to be, what your protocol needs to be to make IVF successful. So if that's all the things in regards to the egg, then we know we need a normal uterus. And whether you're using a gestational carrier or you're going to carry the pregnancy yourself or your partner's going to carry, we want to evaluate the uterus and make sure it's normal. The lining has to go through a specific stage of thickening to allow for implantation. And that's one of the parts of investigation that we do. We also know that even though the tubes are not a part of IVF, if they're damaged and they're really dilated and inflamed, they could potentially hold on to fluid that could lead to a toxic environment within the uterus. So evaluating the uterus at the same time, we're also looking at the fallopian tubes to make sure there's not any significant damage that would potentially cause a problem even when going through IVF. So the uterine lining, once again, at the time of an ultrasound, we're looking at this to make sure that it is getting thicker, forming this specific pattern that makes it responsive and allow for implantation going forward when planning for an embryo transfer. So that's one of the features when we're evaluating the uterus. We're looking at the cavity to make sure it's normal, but we're also looking at the lining to make sure that it's forming a specific pattern, which is going to allow it to be receptive to an embryo in the future. So how do we evaluate the uterus? Well, a simple ultrasound is good. but it's not going to look at the cavity, which is a potential space that when you put fluid in it will open up, and you'll be able to see, all right, what if there's a small piece of tissue in there that shouldn't be there? So something like a polyp, which is an overgrowth of tissue, something like a fibroid, which is a smooth muscle ball that can push into the uterine cavity and can cause a decline in pregnancy success. So by doing a saline sonogram, putting fluid into the cavity, we can determine if there's any abnormal tissue there that may potentially need to be removed before we do any treatment. Same thing, we can look at the shape of the uterus, make sure that the shape isn't abnormal, and we can look for things like scar tissue. So if that puts us into the testing for the eggs and the uterus, the last piece is a sperm source. And so whether you're in a heterosexual relationship, planning to use a partner who has a sperm, we'd want to do an analysis to look to say, all right, what's the concentration, what's the motility, and how does the sperm look under the microscope? And that helps us recognizing that you don't need a lot of sperm to do IVF, because you're going to single-handedly typically pick the best sperm and inject it into an egg. But it tells us about the quality. So if the numbers are low, we can still use the sperm, it just may decrease the fertilization rate, and that tells us more about that. And sometimes there's medication that we can do to boost these numbers and boost the health of the sperm. If someone is using a donor, we'd go through the specifics of how to select a donor, what are the specific testing you want to do before you select a donor. If we dive a little bit deeper into male reproductive health, and that's not necessarily what our focus is, we certainly have other tests that we can look at if low sperm counts is one of the issues, and that may be needed to determine if there's something else going on that we could potentially improve before doing IVF. So other testing that's recommended is to make sure that we're doing the hormone checks. From an FDA perspective, we do have to do infectious disease testing ahead of time in order to store embryos. And then one of the recommendations would be to consider genetic carrier screening. So if you're going through, you're making embryos, we want to make sure that the egg and the sperm source are not both carriers of the same recessive traits. So if someone carries a gene that's abnormal, like cystic fibrosis, it typically is not going to cause them any problems. But if they had 2 copies of that abnormal gene, that means they would have the condition, which a lot of these conditions are life-threatening. So if you check the sperm source, the egg source, you want to see, once again, if they're carriers of the same trait, because if they are, then the baby has a risk of having that disease. And an option would be to then screen an embryo before you transfer it to determine if it had the disease, and then consider to not transfer it to then hopefully not have a child that's affected by that condition. Other things that we think about are just lifestyle things and our health in regards to our BMI. There's data to suggest that with higher BMIs starting to get above the 30 to 40 range, there may be decreased pregnancy success, higher risk of miscarriage, and overall complications in pregnancy. So we want to optimize that. That being said, doesn't mean that you need to be at this optimal BMI in order to go forward. It's just us trying to work together to see what's going to make for the healthiest pregnancy. And a lot of times we can do this in tandem while we're going through and starting the IVF process. We talk a lot about COVID, but Zika is still an issue. And we think about this in regards to people that travel and make sure that we're following the CDC guidelines to not increase the risk of Zika during this process. Nutritional support is important. So thinking about making sure you're taking a prenatal vitamin with folic acid that reduces the risk of neural tube defects is important for everybody. Other vitamins that we talk about are antioxidants. We talk about vitamin D since there's a large deficiency, which can cause an issue in pregnancy outcomes. And go through the importance of taking vitamins leading up to the cycle and then going through the IVF process to try to increase the chance of us getting a healthy egg. So after a workup, we want to talk about your goals. Short term, getting pregnant, but also long term, the option of, okay, is someone wanting to have 2 or 3 children? And the option of then doing IVF is the goal to freeze multiple embryos to then hopefully be able to come back if someone wants a 2nd or 3rd baby, to then be able to use those embryos and have a much higher success at an older age. So those are really important features to think about when deciding what treatment option to go with. So infertility is certainly tough, and I'm assuming most people on this call it's one of the things that we're struggling with. And it's a pretty common thing. And I think that the stigma behind it is very tough, and it makes it harder and creates barriers to get to treatment. But certainly we're here to say that it is common, and you probably have gotten to the point where you talk to more and more people that have, said they have infertility. And it's something that needs to be addressed. And I think we all got to be advocates to try to make sure that we break the stigma in the best way that we can. So thinking through what is IVF? So IVF goal is to try to recruit as many eggs safely as we can in 1 month, to then be able to retrieve them with a goal of having more eggs, which will get us to a healthy embryo. And this is done typically over about a 10 to 14 day time period to grow these eggs by taking medication and then to be able to take them out. So how do the injections work? So you take these injections, which the good news is they're subcutaneous, little injections into the belly, and they stimulate the ovaries to not just make 1 egg, which was what normally would happen, and try to make 2, 3, and then really the goal is to get closer to 15 to 20. Because if you get these many eggs out, we know not every egg is going to be healthy, not every egg is going to fertilize, and not every embryo is going to make it to this stage where it can be transferred. So the more eggs we have, the higher the chance typically that we're going to get a healthy embryo. So taking these medications, our goal is to be there to teach you to have good communication, recognizing that most of us have not just taken injections on a daily basis to ourselves. So having a primary nurse coordinator, having a med teach session, and having the availability to talk with someone on a daily basis is important. So we all feel really comfortable when we're giving ourselves injections. So then how does the egg retrieval work? So after we know the follicles have grown and the eggs have gotten large enough, which is usually 16 to 18 millimeters, you take a trigger shot, which matures the egg. And the day you come in for the retrieval, usually you're there for about an hour and a half to get set up, get your IV, get light anesthesia, and then the procedure itself only takes about 10 to 20 minutes. So a little needle will go in through the vagina. It'll be able to aspirate the eggs that are growing that month, and they'll be taken to the embryology lab to be evaluated, and then the sperm and the egg put together that day. So after the eggs are retrieved, we're going to, once again, put the sperm and the eggs together if we're making embryos. And we typically expect about 50 to 70% of the eggs to fertilize. Then we watch the embryos grow in the lab for 5 to 7 days. We normally expect about 30 to 50% of the embryos to make it to this stage called a blastocyst, where the embryo is made up of about 150 to 200 cells. And this is where we have the option to either transfer the best, freeze the other ones. We have the option to biopsy the embryo, which we're going to talk a little bit more about, or we have the option to freeze them all with the ability to come back in the future and transfer the best one. So thinking about genetic screening, this is an ability to screen an embryo to know which one is potentially the best to transfer. So we grade the embryos regardless, and then could transfer the best embryo based on grading. But if we biopsy an embryo, we can study the cells within the embryo to determine if they're chromosomally normal. So when we typically talk about pre-implantation genetic testing, we're talking about looking at a chromosomal copy number to make sure that that embryo has 46XX or 46XY based on if it's a male or a female. We know that this is a helpful tool, especially as we get older, because we're more likely to have chromosomal abnormalities as we age from a female perspective. The important thing is to recognize that this isn't a perfect test. It's about 90 to 95% accurate, so it's not perfect, but it does bring a lot of information to us. And especially for someone who's advanced maternal age, this can be a very helpful tool to be able to select the best embryo. So who is this recommended for to do the genetic testing? Someone that has a history of recurrent pregnancy loss, because we know there's a high proportion of those patients that have a history of chromosomal abnormalities within those embryos. If someone has a history of failure, if someone has a history of a condition, a genetic screen condition, then you might want to biopsy and test for that. One of those was that cystic fibrosis that we talked about earlier. Older age, as we talked about, more specifically from a maternal standpoint. So there is certainly a benefit, and there may be patient population that it benefits them more. And the help and the benefit of doing this is we know the chromosomes to the best of our knowledge, and the accuracy of 90 to 95% may decrease the risk of miscarriage. And one of the options would be to find out the gender if you cared. Some people don't want to know, and that certainly can be left off the results. And some people decide they don't want to do PGT. And the downside is the risk of having to biopsy an embryo. It's important to recognize we're taking a biopsy from the part that will become the placenta. So the risk to the embryo is small. We typically would say it's less than 1 to 3%. The cost may be one of the biggest issues, because a lot of times insurance may not cover this, and there's an added expense. And then if someone was really hoping for a fresh transfer, we do have to freeze the embryos in our centers and in most centers across the United States to wait for the information to come back prior to the transfer. So thinking about the steps of what happens after the eggs are retrieved, we can then decide and have a good estimate, understanding of how many embryos we may potentially get based on averages. So if someone is having an ultrasound and they're developing about 12 follicles, we can assume that about 80% of those follicles are going to give us a mature egg. So that would then be 10 eggs retrieved that were mature. When we put the sperm and the eggs together, if the sperm quality is good, we'd expect about 70% to fertilize, which could lead to 7 embryos on day 1. Typically 30 to 50% of those embryos will develop to that blastocyst stage, which is those 150 cell embryo. So that put us in the 2 to 4 embryo category. And then if you did go forward to biopsy, depending on your age, that'll tell us what's the likelihood of that embryo being chromosomally normal. So someone that's 40 has a 30 to 40% chance an embryo would be normal. Someone who's in their 20s has like a 70 to 80% chance that an embryo would be normal. So you can imagine this could vary a lot based on your age group. And then at the end of the day, every time we transfer an embryo, the success rate is going to be based on 2 main things: your age, and then if that embryo was genetically tested or not. So why and when do we decide to do a fresh or a frozen embryo transfer? So a fresh embryo transfer basically means that after the retrieval, we put the sperm and the eggs together, we grow the embryos, we can transfer an embryo 3 to 5 days after the retrieval. A frozen embryo would be, well, we're going to wait, freeze them, and then typically the following month come back, thaw them, and then transfer that the same day. So why is it commonly recommended to do a frozen embryo transfer? Well, if someone's at risk of developing hyperstimulation, so they have high levels of their estrogen in their body, they have a lot of follicles growing, then they're at risk of getting sick from having too much hormones. And so then we want to freeze the embryos to make for a higher success of transferring the embryo and to not exacerbate the symptoms that someone is feeling if these hormone levels are high. It also then allows us that if the hormone levels are high, then a lot of times the uterine lining is not in sync and is not going to be as receptive to a fresh embryo transfer. So then if we freeze it, we can come back, we can focus on the uterine lining, and it'll make the success of a transfer higher. And then the ability to do the pre-implantation genetic testing, we do need to freeze the embryos, which would then require us to do a frozen embryo transfer. So this is an example of a calendar, which the goal is to be very organized, to keep your stress as low as you can. And so this shows an example of someone who is potentially going to start their medication, and then when they're going to go through, when they're going to come into the office for an ultrasound, we're going to recommend when to start progesterone injections, and then when their embryo transfer is going to be. So typically from when you start medication to the transfer, it's about 2.5 to 3 weeks to be able to get the lining as thick as it typically needs to be and have the progesterone to make the lining sticky and ready for a transfer. So then how does the embryo transfer work? So this, is certainly, less invasive than the retrieval itself. So someone comes in, sometimes they'll get a little bit of medication prior to the transfer to relax the uterus, which is not always needed, but one of the medications that can be used is Valium. A small catheter goes into the cervix, and then the embryologist load the embryo and we feed that through the cervix and be able to watch the embryo get placed into the uterus on ultrasounds. So we assume you're going to be pregnant after the transfer. So you're going to do all the things that would typically be recommended of someone that's pregnant. And then usually anywhere between 8 to 11 days later, we do a pregnancy test because we know that the embryo is already a few days old. So we can actually test earlier than the typical 14 days. So what does success rates look like? And so a lot of this hinges on the type of treatment and the age and whether someone has done the PGT screening. So comparing an IUI cycle or doing an ovulation induction cycle versus IVF, the success rates are substantially higher. And they are going to vary based on your age, but overall, most of the time, success of IVF is going to be substantially higher. So if you compare for someone who's 35, a typical success rate with doing an IUI or timed intercourse is about 10 to 15%. Now, if you compare that to IVF, success is closer to 50%, And if you have a genetically screened embryo, the success rate is probably closer to 65%. So it's hard to argue against that. Certainly the downside of IVF can be the cost, but the success rates are substantially higher for most patients. Now you compare the age group, and it's important to recognize that it may take more than one IVF cycle to have success, especially as you age. So when you compare someone that's 35 and say, okay, the success rate of doing one cycle may be closer to 50%, but if you're 41 and the numbers have gone down and the quality is lower, it may be closer to 20%, which means on average, someone may have to do more cycles the older they are. And take into account age and ovarian reserve are those two really big predictors of success. So I would say at Kindbody, and I think most reproductive endocrinologists, we recognize that not everybody's path is the same. And we want to think outside the box. We want to be innovative. And I think one of the helpful things too is that we have psychological support here, recognizing that this is a pretty tough journey and everybody needs help in an individualized way. So the other things, and we talked a little bit about at the beginning, depending on how you put your family together, we have the options of doing third-party services, which basically just means using a sperm donor, egg donor, or gestational carrier, or an embryo donor, embryo donation. So we have all of those options, which are in-house, and we call that our family building group. So for a sperm donor, we talk about the specifics of deciding if you're using an identified donor, a known donor, or a non-identified, which we used to call anonymous, but it's hard to be anonymous anymore with all the testing like 23andMe. So the option of a known donor versus a non-identified. And then for an egg donor, we have our own in-house bank where we go through the options of someone who's already frozen eggs that they've donated, or potentially someone who's going to go through an IVF cycle, stimulate their ovaries, and then donate their eggs in a fresh cycle. And then embryos, so someone who's already completed their family and wants to donate their embryos would be an option to then be able to adopt and have an embryo. A gestational carrier too, we have our own in-house gestational carrier agency. So the ability to transfer an embryo into someone who can carry the pregnancy, depending on how you put your family together, that would be an option. And we would be able to work with you to be able to organize that. So I think it's important to recognize, at the end of the day, it's not one specific path to pregnancy. And the goal would be to just get as much information as you can to decide what is going to work for you to be able to go through this journey. And we're lucky to have the resources. And I think we're all very passionate about our job to be able to provide the best care that we can. So next steps to be able to, move forward. I think if, you're ready to just get more information, I would say it makes sense to make a new patient appointment. Obviously, I'm always an advocate of people to do their own research, figure out what makes the most sense for you. But I think getting an appointment, figuring out your ovarian reserve, there's not really any harm in that. And we know that, knowledge is power to be able to decide how quickly someone needs to go through and decide to do treatment. So there are Kindbody locations all throughout the United States and continuing to grow. I bet if we did this talk next year, there's going to be a lot more dots on here too. And the important thing is we have telemedicine. So even if you're not in one of these locations where there is a Kindbody clinic, we can still see you and have some of the workup done potentially closer to home, and then have someone come into the office to have their procedure done, which is what we do all the time.